Hi guys, welcome to my YouTube channel. My name is Heidi, also known as the Transcultural Nurse. If this is your first time to my channel, welcome, and if it's the second time, then welcome back. This channel is all about nursing transculturally, which is being able to nurse people from all cultural backgrounds. In the field of mental health nursing, you know, it's widely known that people from different backgrounds, particularly ethnic minority backgrounds, Black people, South Asian people, people whose first language isn't English, often fare a lot worse in the system. For me as a nurse, I want to put it out there that this isn't right, this is wrong. So this isn't just directed at nurses, it can be directed at anybody, maybe somebody who's actually gone through mental health, you know, crisis themselves or suffering with long-term mental health problems. I'd be interested to hear some feedback. So if you think this might be for you, I'd say subscribe to my channel, share it and like it, and I will keep bringing you content, okay? It's important that we all kind of talk about these issues because from my experience as a nurse of 12 years, it's not talked about enough, okay? And I've seen throughout my career, you know, detentions and unfair treatment of people usually from Black and South Asian communities at far higher rates, when really I don't think the work's been done in terms of looking at culture, you know, looking at health beliefs and things like this. So this is what the essence of my channel is about. So stay tuned for my video and all will be revealed. So this video number 2, I want to give 2 case examples, okay, of different people, one from a Black African background and one from a white English middle class background, okay. These cases are based on real life people. A pseudonym will be used just for anonymity purposes, although we'll know who these people are. But for the purpose of the video, just to make it a little bit more fun and just to mix it up, the background is embellished a little bit, okay? But the point is, I want you to see how people from different cultural backgrounds can end up within the mental health system, the pathway to care, the treatment, and ultimately the outcomes, which can vary considerably. So this is pertaining to culture, it's pertaining to the assessment process, it's looking at health beliefs, idioms of distress, you know, expressions of distress, which might kind of, you know, show how a person feels through something that it might say, not necessarily a behaviour. The point is, I want you to be able to distinguish between how people are treated, okay? Because when we're doing assessments, we have unconscious biases. You know, we might treat people differently according to where they're from. We might have the racial stereotypes going on, okay? We might think people might act a certain way because they're from there, but actually they might not be that much different from ourselves. So I'm going to get into it. I hope this makes sense, and please give me some comments, please give me some feedback, because I need to know that this is reaching the right people. I need to know that this is making a difference, and I need to know that people are learning from it, okay? So prospective nurses already, you know, in the career, or, you know, anyone who can relate to this video, please tell me if this rings a bell with you, or if this conjures up sort of, you know, thoughts, maybe a bit thought-provoking. Let me know, and, you know, I'd love to be able to do more and keep giving you stuff like this to think about. Okay, you ready? Okay, so meet Freddy. Freddy is a 62-year-old Tanzanian man, currently living in the UK. He's not known to mental health services, so he's recently been picked up and detained on a section 136 of the Mental Health Act, which is removal of a person from a public place to a place of safety if they're suspected to have some kind of mental illness. So he's been picked up by the police for being seen in the local community, preaching about the word of God. He's saying that there's some kind of illness going around affecting his people, and this illness has been sent from the devil to harm people. Freddy is surrounded by people from his congregation, from the church. He's a Christian man. Yeah, other people are coming around to listen to what he's got to say. Yeah, he's quite passionate, he's preaching, he's raising his arms, he's shouting from a megaphone, he's wanting to let people know what God's saying. So Freddy is saying that he's heard the voice of God telling him to spread this message to the people, okay, not to fear. He wants them to surrender to God, pray, fast, cleanse themselves, and only eat organic localized fruit from Africa. He's saying with conviction that there's something wrong, that there's something affecting his community, and he's spreading the word of God to try and protect himself and his people, okay? Police are saying this man is acting very bizarre, he's breaching the peace, we feel that he's a risk to the public, so the decision is made for him to be taken to the local psychiatric unit for assessment. Okay, so Freddy gets to the crisis assessment unit. The assessment process does take a lot longer than this, but I'm going to condense it down just for ease, just so that you understand where I'm going with this, okay? So Freddy's taken to the local crisis assessment unit. On presentation, he is, appearing a little bit elated, a little bit grandiose, saying he's hearing the voice of God and he's a messenger from God, wants to spread the word to his congregation and the community because he's concerned, he's thinking too much. He's saying he's thinking too much, okay? He says he's never suffered from mental health problems before and doesn't believe it exists, okay? He's a good man, he's a man of God, and therefore he feels protected by God to do God's work. So on assessment, there's no previous mental health conditions known. He doesn't appear to be a risk to other people or himself. He's saying he's thinking too much, okay? And basically, other than the fact that he's a little bit irate because he's been detained against his will, he's not presenting as a threat. However, on the handover from the police are painting this picture that he's causing disturbance, he's intimidating, he's a conspiracy theorist, he's spreading propaganda. Okay, so he's taken in on the basis of his thoughts, his religious belief, his devotion to God, the fact that he's saying that he's heard the voice of God and needs to send a message to protect people. Okay, there's no other mental illness, there's nothing else to, there's no other justification other than that. So he's been assessed on the unit, the doctor's seen him, there's no previous mental illness that we know of, not known to services. The doctor's twiddling his thumbs and thinking, well, what could it be? It's looking like first episode psychosis. He's making reference to God a lot. Religiosity's apparent. He's saying he's hearing voices. Yeah, he's delusional. He's saying that he's been sent by God to do God's work. We understand that there's a genuine, level of, religious faith, which is part of him, part of his culture. However, we're concerned that, the message that he's sending and the fact that he's saying he's thinking too much, his presentation, him appearing elated, he's not easily calmed down when we're trying to reassure him and tell him that he might have a mental problem. We feel that he could potentially be not a risk to himself necessarily, but a risk to other people by, inciting these things. So we're giving him the diagnosis of first episode psychosis. We're going to suggest to the gentleman that he remains in hospital for a period of assessment, on a Section 2 of the Mental Health Act, and he's not happy about this, okay? So he's not normally violent or aggressive, but he does start shouting and, kicking off a little bit, which gives them more justification to say, well, this man's demonstrating that he's not safe, staff feel threatened by him, so we're going to keep him in. So basically, a Section 2 is admission for assessment, and it's for up to a 28-day period. Yeah, so a person who's detained under a Section 2 can be discharged within that time. So Freddy's gone on the ward, detained under Section 2, fuming, absolutely fuming that he's been detained. As far as he's concerned, there's nothing at all wrong with him apart from him thinking too much about what's going on. He's heard of 4 friends who've become really unwell with this condition. They've not been in hospital, but they've been very unwell, and he's concerned that this is being sent by the devil. Okay, he's a man of God. He's well known in his faith community. He's saying to people, you've got to listen to me because I've taken a message from God to spread this word. Whilst on the ward, he continues to profess this about God and him being a messenger and that people have got to look after themselves. Nurses are becoming increasingly concerned, saying this man's clearly psychotic. He's asking for a Bible. You know, he came empty-handed with just the clothes on his back. Yeah, they didn't tell him that there was chaplaincy. They didn't tell him that there was spiritual support for him. Yeah, they've just kind of noted down what he's saying and have read into it is that this man's psychotic. Yeah, clearly irrational, totally, you know, the religious elements present and dominant. Yeah, there's nothing else to report other than he's causing a disturbance on the ward and that he's worrying the other patients. So this man's prescribed against his will a moderate dose of an antipsychotic to trial, okay? And he's having none of it. He's having none of it. He's not causing a disturbance in terms of violence or aggression. However, his presence is becoming a little bit more intimidating by staff. As the days go on, he's still, you know, saying the same thing with conviction. Nothing's changed. They're saying that there's been no improvement in his mood, in his condition. He's starting to appear more flat in his mood. Yeah, he's becoming more down, depressed. He's not able to see his family. So it's decided on further assessment that they should maybe detain him on a Section 3, which is admission for treatment. Yeah, against his will. He's given so he's been refusing his oral antipsychotic. He's been given an injection against his will under restraint because he refused to have it. Becomes even more flat, sedated, you know, can't even attend to his own personal care. Detained on the ward for another 3 weeks before they actually realise that this man is saying the same thing despite being given this medication. So it's decided by the nurses and the doctors and all involved in his care that actually this man should be discharged from hospital. He's discharged with very little follow-up. He gets a community mental health nurse to visit him for a period of time, but he's discharged. He's had no spiritual or pastoral support. They've totally overlooked his religious beliefs, where he's from. They've not made mention of the fact that he's from Tanzania, that he's currently living in England, you know, and that he's a man of God. He's well known in his community. He's a well-valued member of his church. Yeah. This makes him feel very fearful and very paranoid and very concerned that if he goes to church or in his community again and says the same things, that he's going to be detained again. Yeah. So the point is, in this case, can you see where it's gone? It's gone from a man who is basically saying what's from his heart, what he believes in, trying to protect people. You know, there's no previous mental illness, none known. You know, he's not been particularly threatening to anybody, apart from, you know, being heard speaking aloud in public. Can you see how, you know, racial stereotyping happened? He's a black man in the community being loud, you know, intimidating according to the police. You know, this is justified in being taken away, detained, treated unfairly, treated with medication that didn't change his condition or his beliefs or anything. He's come out discharged with very little of a care package. Not that he really needed it in the first place, but, you know, they've not even attended to his spiritual needs. He comes out totally disappointed, has no faith in the health system anymore. Yeah. The church people are saying now, this man's crazy, he's been in hospital, even though they've known him, but there's a stigma associated with mental illness. Okay. So can you see how damaging this can be to people? Yeah. Can you see how damaging it is to people when, you know, nobody's done a thorough assessment? I mean, I've not gone into the ins and outs of the assessment because in nursing we do what's called a biopsychosocial assessment, which looks at the biological factors, psychological factors and social factors, okay? And the social factors really should include cultural factors, but that's more often than not missed out. So in this instance, this is very common. And this is why we see an overrepresentation of particularly black people. You know, it could be black, African, Caribbean, black, British, you know, even South Asian. Massive overrepresentation, like 4 times more likely to be sectioned. And this is often why. Yeah, so I want to do another comparison and I want you to, obviously different people, totally different, but this is what it is in mental health. You don't get 2 people the same coming through the door, okay? But the treatment can be very different, okay? And I'm not saying that people should be treated the same, but in terms of how people are treated from the off, isn't judged, you know, stereotyped, you know, thought of as less than because they're from somewhere different or they don't speak English. You know, people can be really disempowered when they you know, they're not from this country, they don't know the system, they don't speak the language, and therefore I just want this video to highlight how this can happen. Okay, so case number 2. Meet Timothy. Timothy is a 58-year-old white British male, self-referred to mental health services, feeling very anxious. Okay, he went to his GP. GP said, okay, I think you're probably suffering from anxiety. So Timothy took it upon himself to contact a telephone number which can, you know, offer support and therapy for people who appear to be suffering from anxiety-related disorders. So Timothy rings the number, explains that he's been very unwell of late. He was recently diagnosed with pneumonia, was in hospital for 2 weeks, treated in intensive care. Due to exacerbation of symptoms, he was very unwell and thought he was going to die. Okay, he pulled through, and since being discharged from hospital a week ago, he's been suffering from recurrent nightmares, concerns that he's going to die. Yeah, his anxiety is quite debilitating. He's constantly washing his hands for fear of contamination. He's ruminating. He doesn't want to go out and touch anything. Yeah, he shows insight into his condition. He's explaining whilst on the phone that he is possibly suffering from anxiety. Yeah, and, you know, possible OCD as a result of becoming infected with an illness, okay, which has caused him to have pneumonia. So Timothy is referred for CBT, which is delivered at his local GP practice. Yeah, Timothy is satisfied with this. He has to wait a couple of weeks to be seen. In the meantime, his GP has prescribed him a start dose of an antidepressant, okay, and an anxiolytic. He's been given some diazepam to help him sleep. He goes to therapy. He's satisfied with how it goes for the first time. He never had it before. He's never had a previous history of mental illness also. And so he begins on his journey with CBT. Satisfied with this, he continues on his medication prescribed by his GP and goes back to his GP after 4 weeks for a medication review. Everything seems to be improving. He's discharged from therapy after 8 weeks, and he maintains himself on a low dose of antidepressants, and he keeps the diazepam for days when he feels a little bit anxious. But all's well for Timothy. So, as I explained, 2 very different cases, and I'm using these cases to highlight the differences in culture. Not only culture, but the differences in treatment, the difference in pathways into health. When somebody recognises that they have a condition, for example, an anxiety disorder, things are generally a lot easier, you know, especially if you're from a culture, like, for example, if you're a white British man who's, you know, within the dominant culture and, you know, where mental health is accepted, it's more socially acceptable to have a mental illness, although for men it's not always talked about easily. But he feels upon, you know, during this time, he recognises that he's not his usual self, and therefore he goes to his doctor. The doctor's like, yeah, you know, we recognise this, you know, from you. It's not, you know, you're not being unreasonable to say that it's anxiety. You've gone through a lot in the last few weeks with your illness. You've been in intensive care. You know, there's a lot more empathy shown to this man, and he receives talking therapy and a you know, a low dose of medication to begin with. Yeah, whereas example number 1, Freddy, you know, he's concerned, maybe some anxiety related, you know, symptoms there, in that he's fearful for himself and his community. But he is treated completely differently because, you know, he's not saying I have anxiety and, you know, what I'm saying is irrational or anything. You know, rightfully, if he's concerned, he should be able to express it in the way that he feels is right and in keeping with his culture and his health beliefs, you know. He's saying that he's receiving a message from God, and maybe he is. I mean, who are we to say that he isn't? Because people do hear the voice of God, okay? But the result from that instance is that he's taken by the police because it's not within the social norms of the dominant culture within England to stand there and preach, you know, about these things. And in a time like now where, you know, speaking out about certain things is very frowned upon, you know, I want it to kind of highlight that this isn't just fictitious. This happens day in, day out. In my role, especially when I worked in the crisis service, people would come in every week, you know, every day, you know, and I'd see like a name which, you know, wasn't an English sounding name, it was often an African name, and a lot of these had like a religious element to the presentation, but it was always a case of, oh, this person again, or this person's come in, very similar patterns. And, you know, you think, well, there's nothing actually wrong with this person, or this person is very anxious, but they're saying this is their way of understanding and experience their illness. Yeah, when someone's talking about God, maybe they think that God is part of the cause of the illness, but they don't see it as an illness, and there's nothing wrong with that. That doesn't mean that person lacks insight. So I want you to start thinking, you know, maybe you setting off in your career, and I might be seeing similar patterns in your area of work. I might be thinking, why is this? Or there's a similar, I don't know, spiritual element to a lot of what people are saying within the presentation. What can I do about it? Well, the first thing you can do is listen and understand, you know, and don't be afraid to say, how come all these people are coming into our services and we're not even considering the spirituality? Why? Like, why not? Because although they might be unwell, they might have an underlying condition, they might have, you know, a diagnosable condition. Without tackling that element of that person's culture, they're never going to get proper treatment. You can treat them all day long for the symptoms, but unless you dig and unless you delve and unless you try and understand how that person perceives what's going on for them in the context of, you know, the religious element, the spiritual beliefs, the culture, what the family think, you know, their worldview, they're not going to get the same level of treatment as what they should. You know, negating these elements of a person's lifestyle or culture means that the treatment that they get is second class. It's not good enough. Okay, so I'm going to do a separate video on culture, because on its own, it is quite difficult to understand. It's easy to understand if you look at it as though, you know, we're all shaped by our experiences, you know, the way we're brought up, where we live, where we've travelled, you know, all these things shapes us, and culture is not static, it can change. Yeah, but it's a video which I feel needs its own time, you know, in order to be able to sort of give credit to these videos, it needs explaining a little bit more in depth. And I'm going to come back to these case examples to try and break it down, maybe break the assessment process down, so you can understand why it's important to talk about different factors of a person's being. Because it's all well and good doing a biopsychosocial assessment, you know, we can look at the housing needs or the family needs, or, you know, all day long, but in the context of a person's culture, you can't negate it, you cannot leave it out. So example 1, Freddy. Example 2, Timothy. 2 completely different cases, 2 completely different, you know, men. Symptoms are different, you know, the way they've been handled and processed being completely different. One's satisfied with his outcomes, you know, it's been quite smooth, he's kind of gone along with it, feels the benefit. The other one is totally been neglected. Yeah, he's been dragged through the system by force. Yeah, he's still of the same convictions as he was before he went into hospital, yet he's come out more fearful now of the system, feels that people are against him, you know, and it's been damaging to him in the community. It's been damaging in terms of how people view him now. I hope this video, again, has been food for thought. You know, it wasn't intended to be too in-depth at this point, because, you know, this subject is not easy to be taught even. I mean, I've done a course in transcultural mental health, and it's like, honestly, it's like a can of worms. Once you start unpicking the surface, it's so deep. and meaningful, but I'm trying my best to try and make it basic enough for people to understand and people to reflect upon, and actually, you know, use bits of what I'm saying in their practice to get them thinking and maybe practicing in a different way, you know, or start to ask questions differently. And hopefully you'll be able to see in yourself where you've maybe had biases, or where, you know, your own culture and worldview have led you. Okay, so thank you for taking the time out to watch my video. Like I said, if it resonates with you, if it helps you in your practice as a nurse, or even if it's, you know, if you're a person, any person who's been through the system and you felt that your needs haven't been met for whatever reason, it could be that you've got different health beliefs, you might not believe in conventional medicine, you know, you might be very spiritual and believe that what's happening to you has been from God, you know. I want you to watch this and support me, but also I want to support you. So I'd appreciate any comments, any feedback. You know, if there's anything that you want me to discuss, I'll do my best. I'm not an expert, but I'd happily give it a go, okay? If it helps one person, then this is worth doing. It's worth me being out of my comfort zone and doing something which I'm totally not used to doing. You know, I'm not a lecturer, I'm a nurse, but I feel passionate. I don't like to see people, you know, being treated unfairly, you know, because of the beliefs or the background or anything. So I'm here as an advocate for you guys, okay, and for the nursing profession. So please subscribe, please like this video, okay, and share far and wide, and please come back and see any future videos which I make, okay guys. Thank you so much. Bye for now.